You listed all the modalities, all of our modalities. The issue is how to get this accepted.
I want to practice medicine like a doctor, not like a insurance form filler.
Do you think that the problem is like the science, or do you think it's something else? What do you think? What do you think is the main reason why we're back?
If I had to kind of put it into like a small little nutshell, I would say the reason is just fear.
I've heard of, T cells and all that. For those that are not really familiar with that, can you kind of go over what that is?
The most powerful chemotherapy agent in the world, hands down, beats everybody, is your own immune system. It goes, number one, it doesn't cure anything, right? Because if you cure patients, you're going to lose a customer. So it doesn't cure anything. Number two, it controls symptoms only. Okay. Number three, if you stop taking it, the symptoms come back worse.
Why do you think that they are gatekeeping, and why not adapt into something that is going to revolutionize, right? And honestly, like the field, but at the end of the day, we're talking about helping patients.
People always fight the disruptor. They don't want disruption, but disruption is what builds innovation. I don't appreciate the gatekeepers. They cancel people, they close down things, or they close down arguments. Honestly, that's just weak. If you're weak, get the hell out of the way then. You cut off a leg off the salamander and it grows a new leg. Well, guess what, boys and girls? You can do the same thing with the liver. Just keeping people alive longer is really not worth it. But if you can have somebody who's 70 or 80 and make them function at the level of a 40-year-old again, that's...
So, Dr. Shah.
Yes.
You've popped up out of nowhere. I mean, at least from my perspective, my point of view.
Yes.
I see you everywhere, talking to everyone. You're in all the circles that I'm in. So
Yes.
for those of the people that don't know you, who you are, what you are, who are you?
Yeah, sure. So my full name is Dr. Hasnain Haider-Shah, but I always go by Dr. Shah. So understand the reason I'm probably popping up now, because I really wasn't in the States. For the last 18 years, I was in Dubai and working in Dubai, and I like working in Dubai. It's a very nice place, and Dubai is one of those cities. Now the Sheikh Mohammed of Dubai announced that they would open up a regulatory authority for longevity, and they want to make Dubai a longevity capital of the world. And this is, I think these kind of things are actually good. I think that where government kind of says, you know what, we see this change coming, and we want to be in on the change, and we want to encourage and foster the change. And I'll tell you, Dubai is very good at making an announcement, and as soon as they make the announcement, everybody, all the private equity guys jump in, all the real estate guys jump in, all the doctors jump in, everybody jumps in. It's all like a big free-for-all. And Dubai is one of those places where a lot of people from many different countries come together, and they do work together. And so it's good, but they're very good, the Dubai guys. They know, okay, let's announce longevity and a longevity authority. And as soon as they did, you should have seen all this investment and all these people talking about longevity and all this LinkedIn articles and everything about. But they're smart. I mean, they're really they know that these kind of endeavors are going to yield results for them. And like, I don't know if you know, but like, I had to do a recent pitch in front of some Wall Street guys, and I started telling them. So they're like, "Well, let's talk about wellness and longevity." And I go, "Listen, guys, the wellness CAGR, your cumulative growth." Annual growth is for wellness is like 12%. For longevity, it's like 14 to 15%. For stem cells and regenerative medicine, it's 26%.
Wow,
So
I believe it.
the private equity guys know that, and they know that this is going to be a very, very big market, and there's going to be a lot of discoveries and a lot of new protocols and a lot of new treatment options that patients will have. And it will only grow faster and faster. Now you can see this is, we started off with simple things, and now we're getting to much more complicated and more complex treatment options. And, before, leukemia and lymphomas were very difficult to treat. And you would treat them, and then they would come back. You would treat them again, they would come back. And I know, because I did some training at MD Anderson Cancer Center, and I remember we would talk about this, and we would talk about how they keep on coming back. You get recurrence. Now with CAR-T therapy, where you take out your tumor, and then you prime T cells to attack only the tumor, and then you clonally expand those T cells, then you put them back in the body. Now those T cells are like little ninjas that want to go kill the cancer, and they're primed to kill only the cancer. So I know you have these little T cell ninjas going out and knocking all these tumor cells out, and guess what? You can now cure some of these leukemias and lymphomas that before we could not. I mean, for what we call blood cancers, This is a huge step. And I think now there's like at least 4 companies in that CAR-T space that are developing products and developing specific products. But before leukemia, lymphoma, it was like recurrent. You recurrence again, again. It was very painful for the patients.
Yeah.
Now we can
For those, yeah, for to be honest, like I've heard of, T cells and all that. For those that are not really familiar with that, can you kind of go over what
Yeah,
that is
sure.
and why
So
it's important?
yes, exactly. So remember, the most powerful chemotherapy agent in the world, hands down, it beats everybody, is your own immune system. You have an immune surveillance system, which is basically like there's little warriors that do threat assessments all the time. They're going around looking for threats all the time, and they're very active looking for threats. And as soon as they see a mutating cell, boom, they label it. And as soon as they label it, the macrophages and T cells and NK cells and dendritic cells and all these other cells, which are cell killers or bacteria killers or fungal killers or viral killers, they will go and kill that whatever has been labeled, right? So the immune system is great. Like you and I always tell people, you and I have 8 to 10 circulating tumor cells every day. Every day you have 8 to 10. And guess what? Every day your immune system goes in and knocks them out. As soon as it sees, oh, this is a mutating cell. This is just should not be here. Boom, takes it out immediately. Like in this, like little. I always say it's like what's that? The famous video game about assassins, Assassin's Creed. They're like
Yeah.
little
Okay.
Assassin's Creed guys, right? They come in with their little
Yeah.
hoods and they go and knock
Yeah.
everybody out. And so, and that's just your circulating tumor cells in your blood. You have to understand you have tumor cells in your solid organs all the time, whether it's the liver or whether it's the prostate or whether it's the breast or whether it's the brain. There are some parts of the body are more resistant, other parts are not so resistant depending on how exposure they get to the kinds of toxins or inflammation or other things that we know are things that can cause DNA damage and then mutation. But the immune system goes after them immediately. And now this is what with the CAR-T, this is what they've done. They've developed and they've basically hypercharged the immune system.
I see.
And so this is something that your immune system, one of the things that I'm big in, not just stem cells but in regenerative medicine, but is oncology, and in what I call interventional oncology. And this is a term that we use, that we can actually go in and specifically go after tumors without the whole systemic side effects from chemotherapy. And I remember there were places, some hospitals I worked in, and I'd be in the tumor board, and a tumor board would be a meeting of all the doctors. So the pathologists, the oncologists, the surgeons, the surgical oncologists, the nutrition guy, everybody would be there, and the radiology and interventional guys would be there, and we'd be going over discussing a case. And there's guidelines. We all use guidelines, right? And the guideline ASCO guidelines or ESMO guidelines or whatever guidelines. And I would talk to the guys afterwards, after the thing, and I would say, hey guys, you're going to do this first line therapy, and based on this how aggressive this tumor is, it's going to fail. And they're like, yeah, we know. I'm like, so then why not? And then we're going to do second line therapy, and then we're going to do third line therapy, and then we're going to do experimental therapy. Well, you know what? When stop subjecting the patient, because these therapies have a certain effect, but sometimes they don't work. Let's just go to experimental therapy first. Let's do what's the most aggressive case for cancer, because cancer is one of those things that really, it's still, depending on the country that you choose, it's either the number 2 or number 3 killer of people, right? Heart disease is always number 1. Number 2, it kind of balances depending on the country between stroke and cancer. Sometimes stroke is higher, sometimes cancer is higher, depending on the country. So, if you know something that is that deadly, let's go after it with the strongest weapons we have, and not just this. A lot of the chemotherapy is like. They have the standard kind of chemotherapy drugs, and they give those, and what I always argue is, well, guess what? When you give the chemotherapy, what do? Well, you kill the chemosusceptible cells. The cells that can be killed by chemo, those are the ones you kill. Well, now guess what's left? You've selected for chemo-resistant cells, and now those chemo-resistant cells are much more aggressive,
Yeah.
and they're going to start growing faster. And that's why you see a lot of patients who get, they have stage 1 or stage 2 cancer, and they get rid of it with surgical, some things, but then they start giving chemotherapy. Well, guess what? Now you have these now chemo-resistant cells, and they start, multiplying at much faster rates, and they're much more aggressive, and they start spreading much faster. So, this is my issue with this kind of things. And, that's why I think regenerative medicine and using the immune surveillance system is a much better option. My
Interesting.
my kind of philosophy on the stem cells and oncology is use what the body does and just hyper enhance it, right? The body's much better at repairing. Body's much better at fixing things. Body's much better at going after cancer cells. So you know what? Let's just harness what the body does. Take whatever the body has and use those elements. And if you can enhance them either through laser or through stem cells or through photobiomodulation or through, let's say, a shockwave or through a high frequency ultrasound or through magnetic therapy, that's a better way to treat people, not just one single way. And
I agree.
the single modality cancer therapy, and I wrote a LinkedIn article about this, that it's a thing of the future, or sorry, of the
Yeah.
past. This is
Yeah.
an anachronism of the past. You know, we should not be doing this. What we do for our oncology patients, we have a multi-pillar approach, and our multi-pillar approach is using many different ways, because the tumor is mutating all the time, and you have to go after that tumor biology. And as soon as you try one thing, it mutates another way. As soon as you try something else, it mutates again. So what I say is, don't give it a chance to do that. So we of course, the basics are always the same. Is that yours or mine? Anyways,
What's mine? Sorry.
yeah. So we'll do the same thing. We'll go after first fix the simple things, and same thing longevity, same thing in interventional oncology. Fix your sleep, right? Your sleep is very powerful time when you have high levels of melatonin, you have low levels of cortisol, and your body repairs and regenerates itself at night. That's why we see people who don't sleep, they age much faster. People who are not sleeping well, they start having more problems. So sleep, we try to fix patients' sleep with sleep hygiene. Then we'll fix their nutrition, right? Because if you're going to have to fight a tumor or you're going to have to repair something in the body and regenerate something, you need really good nutrition. Then beyond that, exercise, right? So exercise is something that is, honestly, if we could make exercise into a pill, it would be every medication in the world, right?
Yeah.
Problem is,
Everyone wants the easy pill, though.
yeah,
The
yeah,
easy way.
yeah, the pill always, but the pill doesn't work. But exercise helps, ramp and charge up your immune system, charge up your cardiac system, charge up your lungs, so that kind of thing, your body is now working much harder and much stronger.
Yeah.
And then you can fight threats that come
Yeah.
up. So,
Yeah.
so we do all that. Then we'll add in peptides, we'll add in bioregulators, we'll start doing photobiomodulation. We'll do photobiomodulation to whatever the component we're going to add in, whether it's PRP or whether it's stem cells or whether it's SVF or whether it's BMAC. We will put photobiomodulation, because what that does is it causes that product to be hypercharged. And the way it does it is, you have mitochondria in all majority of cells, and it's also platelets. Now, that mitochondria is what provides energy for that whatever the cellular product or cellular component is, whether it's platelets or cells or other things. And if those mitochondria are really working very well, now your platelets are going to do a lot more than anywhere else. Now, is it somebody's put a question, I think, out?
Yeah. Those, it was a comment.
Yeah.
You listed all the modalities, all of our modalities. The issue is how to get this accepted.
Yes. So understand, this is why, and this is one of the reasons I left the U.S. and went to Dubai, was I was getting sick of filling out paperwork from insurance companies, right? I knew what I wanted to do. I knew what the patient needed, and I just couldn't get it through the goddamn insurance company. And I would be writing all these letters and justifying this. And, I was like, I want to practice medicine like a doctor, not like a insurance form filler. So I went there, and that was the difference. In Dubai, that was a little bit different, and the system was very different. And these modalities. So this is the problem in the U.S. that we don't have. Some of these things are not FDA approved right now. So there are photobiomodulation is FDA approved, most of it. So most of that is FDA
the
approved.
Devices, right?
Yes, and the shockwave is also FDA approved. High frequency ultrasound, depending on which unit use, they are also FDA approved. And that's the thing. Medical devices get approved a lot faster. Regenerative cellular therapies, this is kind of our point, that this is why I say America, the U.S., North America, Canada included, as opposed to Mexico, which is part of North America, but Canada and the U.S. are behind, and the reason is because, and it's just because you cannot use one. You have a living therapy, right? You have living cells, and sometimes your own living cells, and so that's not a drug, right?
Yeah.
And,
good point.
Yeah, and this whole minimal manipulation. What minimal manipulation? Yeah, you know what? Guess what? When we do a cabbage, when we do a cardiac surgery, we take blood out and we circulate that in a machine sometimes. We do a cell sorter and we put it back in. Well, guess what? That's minimum manipulation. That's more than minimum manipulation. But we don't talk about that. Where you doing that in cardiac surgery all the time? Do we need FDA approval to do that? No. I mean, I'm taking just your blood that you lost. I put it in a cell saver and I inject it back into the body. That way, you don't have to get a blood transfusion.
Yeah. Yeah.
You know,
So, every time we talk, you're always in another country and you're everywhere, right? And
yes,
so you've pretty much been, you've seen firsthand, how other countries are using these therapies, right? And
yes,
so, like, obviously the whole reason why we're having this podcast and this conversation is like, that the US, the American medicine is 10 years behind, right? So
yes,
you've briefly explained a little bit why you say that the US is behind.
yes.
Do you think that the problem is like the science, or do you think it's something else? What do you think? What do you think is the main reason why we're behind?
Yeah, I think if I had to kind of put it into like a small little nutshell, I would say the reason is just fear. I think it's
Okay.
fear. I think there was
At what level? Who is fearful?
well, I think one, people start thinking that there were a few cases, and this is well documented, that there were a few cases of tumors growing from regenerative products, and these are mostly embryonic stem cells or fetal stem cells that were taken from post abortions or other things, and because of that, some tumors formed, and because of that, people started getting scared. Oh, well, these could cause cancers, these could cause tumors. Yes, this is not a theoretical thing, but it depends on which cells you choose now, and our cellular materials have progressed a lot. So we know that most doctors that are using stem cells are usually doing MSCs, and MSCs they usually get and isolate from either bone marrow or fat. Most commonly, these are the things where they get it from. And then, of course, in those components, whether it's bone marrow or fat, there's also a lot of other growth factors and regenerative proteins in those, as you say, milieu of the stem cell, or part of the stem cell niche that's there. Those stem cells are in the fat or in the bone marrow, and there's a niche of all these regenerative and growth factors and proteins and things that all work together in a very, very well coordinated kind of symphony orchestra. The clotting factors do their job, the cytokines do their job, the lymphokines do their job, the specific cells produce certain products, and those products, and the way that we know, and now the big thing people talk about is exosomes. Well, exosomes are just extracellular vesicles, and I know you had some podcasts with some really exosome experts, and are kind of testing and making sure that exosomes. But exosomes are the way I always try to give people the kind of analogies. Think of your stem cells as a factory. It's like your Amazon factory, and they produce everything that you want. Then the delivery trucks, the Amazon delivery trucks, are your exosomes. Sometimes they have the thing that you want. Sometimes they don't have the right thing that you want. And then the products inside are your proteins and different factors, cofactors. Those are all inside the exosomes, and those exosomes then deliver the package there, and then inside the package is what obviously what you want from Amazon, right? But so the same way, exosomes are just a delivery vehicle, and they just kind of pop off like a little bubble. They pop off the cell, and that little bubble has the things that it has to do the messaging and sending the messaging and sending the right proteins out to somewhere else to do the repair or to do the regeneration. And so this is something that now people are talking about exosomes and this and that, and there's a lot of different quality of products in exosomes, and this
So
is why
many.
testing of exosomes is so essential, and making sure you have the right exosomes. And I think the future is going to be, you will have, just like you have right now, you have for the brain, if you want to fix the brain, you'll have neuronal precursor cells, right? You want to get neuronal precursor cells. Or if you want to fix the heart, you have to get cardiac myocyte precursor cells. Or skeletal muscle, you have to get red muscle cell precursor cells. The same way for any part of the body that you have to fix, you want to get those precursor cells, or you want to get those precursor exosomes. So you have the precursor cells, and then they make exosomes for you, right? And now you have, we talk about exosomes, we talk about trillions of exosomes that people inject. Stem cells, we usually talk, billions of cells. And exosomes, we talk about trillions, because they're much smaller, and they don't have all of the immunogenic proteins, your MHC1 and MHC2, which cause immune reactions. And this is why often, a lot of us who've been, like, I've been doing this since probably 2008, 2009, doing stem cell type of things, or regenerative practice, that we used to see some very bad reactions. Patients would get a very immunogenic reaction, and you would see like if they inject into a joint, the joint would become red, hot, swollen, and you gotta have to tell the patient, okay, listen, it's gonna get that way, it's gonna be a little bit inflamed, that's normal, but after some time, that inflammation. So we always talk about inflammation as being bad. Well, not really. Inflammation, as long as it's a graded amount of inflammation, it's not bad, because the inflammation is what causes the repair cells to come in. And if you don't have inflammation, you're not going to get any repair. So what we do sometimes now, and we're kind of, it's funny how things repeat. So there used to be something called prolotherapy.
Yeah,
And
the
prolotherapy
sugar.
was injecting either dextrose or RBCs into an area of the body to get a reaction. And you know what? Remarkably effective prolotherapy. It worked great. I mean, for pain management, it was a great technique. And now some people, develop. Then they develop pro ozone or prolo ozone, right? They're prolotherapy plus ozone, and ozone works a little bit like corticosteroids, but without all the side effects of corticosteroids. And ozone also kills all the bacteria and any other infectious properties. In fact, ozone is what we use to clean blood in most blood banks. They use ozone to kill everything, right? It kills the fungi, kills the viruses, kills the bacteria, everything. Ozone is very good at being microbiocidal, I guess. But the point is that these kind of therapies, ozone and stem cells, and these kind of very kind of complex regenerative therapies, kind of all work in concert, and you want to use them all together. You don't want to just use one and think, oh, well, if I just do ozone, everybody will be better. No, not really. I mean, you combine ozone with PRP, or you combine it with stem cells or exosomes, and then you also have photobiomodulation. And then I always, my friends are always making fun of me, say, Dr. Shah, every time you have some kind of thing you're going to treat, you have like these 12 pillars. Yeah, I'm like, yeah, usually I have like 9 pillars or 8 pillars or 12 pillars. And they're like, why? And I'm like, because the body is a very complex organism. It's a very complex system, and you're not going to fix a complex system by just doing one little thing. You have to do, just like the body works in concert, and it's a symphony orchestra. You have to kind of be able to modify 6 7 different variables. And that's why I use things like somebody's talking about all the modalities, and I try to use, and I'm always discovering more modalities. And that's why I go and travel a lot. Like I'm here in Jakarta, and I was talking to some scientists who are doing some very interesting things. And you've probably heard of Muse cells.
Hmm.
So
Of course.
Muse cells are umbilical derived specialized cells, which have certain marker proteins that are very specific. And we know that, before we used to think MSCs would engraft. By engraft means they would go into wherever there was a deficit or defect, and they would just stay there and start, building that, whether it's cartilage or bone or tissue. But we know that that's not they work. They work through messaging. They are paracrine messengers. And in
Signaling.
fact, the person who came up with the term MSCs, mesenchymal stem cells, said he tried to change it later on, but it didn't really get accepted. But he called it.
Arnold Kaplan.
Yes, exactly. Arnold Kaplan, the very famous Arnold Kaplan. And he said, MSCs should stand for medicinal signaling cells, because that's what they are. They're signaling cells. They give signals. They're kind of like, the construction foreman at a site. And he starts telling people, okay, you do this, you do this, you do this, you do this, and you do this, right? And he organizes it. So, but still, nonetheless, Muse cells are a little different from MSCs. Muse cells can actually engraft, right? And MSCs, when you take them, let's say you take them out of the bone marrow or you take them out of the fat, well, there's a small subpopulation of all those, let's say, all these 100 cells. There's like 3 or 4 or 5, depending on which tissue you're getting them from, of Muse cells. So I have a theory, and I can't prove it right yet, but I think that a lot of the repair that MSCs do is through the Muse cells, right? The Muse cells, you're also injecting those MSCs, whether you're taking it from fat or whether you're taking it from bone marrow, there's Muse cells in there. And those Muse cells go and actually do repair. That's why I think we used to think that MSCs do engraftment and repair. I think there was that subpopulation of Muse cells that were in there. And those were the ones that are actually doing the repair. And of course, Muse cells now you get them from umbilical cord or placenta, and they can clonally expand them. By clonally expand them means you get the cell, you isolate it, and then you grow lots more.
Yeah. Is that the same as like culturing?
Yes. So yeah, culturing, or we say culturing or clonal expansion is the same kind of thing. Cell
Yeah.
culturing, and you
Okay.
kind of keep on building.
So I really want to get that answer from you. The answer from you. So you said that when I asked you about if you said that the U.S. is behind, right?
Yes.
Is it the science or something else? And you said fear. I don't know if fear
Yeah.
of what.
Well, I think there's okay. So I think the biggest issue is in the U.S. especially, there's a very big malpractice system, and there's a fear that if you're doing something that's not so-called approved by the regulatory authorities, you're going to risk getting a malpractice suit or a lawsuit. And so that's one fear.
Okay.
Two is the
Okay. So from the
tumor.
doctor's side, obviously.
Correct, correct. So the
Gotcha.
doctors don't want to do anything that's going to be, possibly considered experimental, right? Unless it's under some IRB type of research guidelines. So that's one fear. The tumor fear, I think that's most people have now kind of believe that that's not really a big fear anymore, because we're not usually using fetal cells. We're not using
Yeah.
those,
Well, I believe it's it's a felony. You cannot. That's one of the
right?
biggest things.
Correct.
And for
Yes.
embryonic.
Yes, you can't use embryonic stem cells. Yes, so that's another thing. The other issue is that there are some people who are gatekeeping and kind of when we talk about this, they're the gatekeepers. They already have some kind of system that they use, and they don't want anybody else kind of coming in with something new. Which I don't obviously that's not science. That's just it's not even capitalism. That's more communistic. That the state produces whatever, we produce this thing, and nobody else is allowed to produce anything else. Well, that's not really
So
the right way. So
yeah,
I think
no, I
all
agree.
these things limit the U.S. And then that's why in other countries, like I'm here in Jakarta, first of all, beautiful country, great people, amazing food, the most amazing cultural dances and performances that we saw at our stem cell conference here. But meeting other doctors, a lot of this is a problem I see. There are some U.S. doctors that you'll see traveling, but not a lot, honestly, because I go to these conferences in different places. Sometimes in Dubai, sometimes in Iraq, sometimes in Iran, sometimes here, sometimes China. China, big. China is very far ahead. Japan, very far ahead. South Korea, very far ahead. Why? Because they and their governments foster, like, okay, for example, Indonesia. So Indonesia now has 3 special economic zones for biotech, right? And they're pushing it, and they want more people trained, and they're bringing in more courses, and they're bringing in more doctors from other places to train their physicians. And I can give you an example because I saw this in Indonesia. Indonesia has the highest stroke rate in the world, one of the highest, right, of ischemic stroke. And so the government realized this was a big problem. So they sent out doctors to get trained in neurointerventional therapy, where we do, and I'm a neurointerventional surgeon, and that's what we do. We take clots out during a stroke. So when a patient has a stroke, ischemic stroke, we'll pull the clot out and reestablish blood flow. So we open up the blockage, and then the blood flows again. The government pushed their people to go get trained in other countries, go get trained, and then come back. And then when they came back, they started training more people, and they became an exponential growth, right? Because each person that got trained another 5 people in their country. Guess what? Now they have one of the best stroke systems in the world, but the government pushed for it, right? Unfortunately, unfortunately, I think the biggest problem in the U.S. right now, honestly, to be honest, is regulatory capture. And people have talked about this. Senator Kennedy talks about this. Other people, Rand Paul has talked about this. There's regulatory capture. You see, every FDA chairman working for a pharmaceutical company without fail.
Yeah.
So when somebody's working in the CDC, next thing you know, as soon as they retire, boom, they're working for a pharmaceutical company because pharma has the big money. And pharma does not want stem cell products and regenerative medicine in the US. And because they control such a huge amount of advertising, such a huge amount of the media, such a huge amount of what goes on TV, all these media channels are all supported by big pharma advertising. And so everybody's going to come out against regenerative medicine because it's going to take away profits from the
Yeah.
pharmaceutical company.
I agree with that, and I also think that not only big pharma, but also I feel all the medical device companies as well. From like total knee replacements, all that
Yes,
stuff, right?
yes,
Uh,
yes.
that's
Yeah,
also a
no,
big because
that's a
doctors
huge
rather
market.
do surgery, right?
Yes, no, it's a huge market, and that it's those are kind of established, as we say, powers that be, and those powers that be have a big profit margin, and they don't want anybody threatening their profits. And stem cells really threaten profits because stem cells actually can not only just fix the symptoms, which is what most medicines do, but they actually fix the problem. And so I remember working for a pharmaceutical company long, long ago. And when I worked for them, I was in the marketing side. And I remember one of the heads of marketing, the SVP, was coming into the talk to all the junior marketing analysts, and we were all like scared. We're like, "Who is this guy?" And this, very smooth, very like well dressed, Italian suit, Italian loafers, slick back hair, very smooth looking guy. And he comes in, he starts, "Okay, everybody get your pen and papers. I'm going to tell you what the perfect medicine is." We're like, "What?" He's like, "The perfect drug. I'm going to tell you what it is." "Okay, what is it?" He goes, "Number one, it doesn't cure anything, right? Because if you cure patients, you're going to lose a customer. So it doesn't cure anything. Number two, it controls symptoms only. Okay. Number three, if you stop taking it, the symptoms come back worse." Yeah.
Okay. And then there's another one I would add to that.
Yes, go ahead.
The other one would be that it will mess up something else for you to have another type of,
Yes.
tell them another
Also,
pill or something.
oh, so he said that. He goes, "We know all medications have side effects. And guess what? We have two or three more medications in the wings to react with the side effects. So we know you're going to get
Correct.
side effects, and we have another medicines to treat the side effects." And then he was like, "And it's very expensive, and it's mandated by the government, and sometimes everybody has to take it." So he was like, "This is a perfect drug." And I just couldn't take it anymore. At a certain point, I just got up and I go, "Listen, can I ask you a question?" And he goes, "Yeah, sure, Dr. Shah." Or I wasn't a doctor that time; I was just a college student. He goes, "Yeah, what's your name?" I'm like, "Hassan Shah." He said, "Oh yeah, go ahead." I go, "Are you satanic by blood or Luciferian in your outlook?" And he was shocked a little bit, and he took a step back, and then he started laughing. And I go, "What part of that statement that I just said or question I asked you, is it your satanic part that makes you laugh?" And he's like, he started laughing again. He goes, "Listen, I am not the satanic one." He goes, "I'm a marketer. I do marketing. I'm very good at what I do." And he goes, "Our shareholders, they demand a profit every quarter. And if I don't produce, I'm going to get, as he said, S-canned. I'm going to get thrown out of my job. So we have to produce, and I'm not the one who makes the medicines. I just market them." But he goes, "The shareholders, yeah, some of the shareholders are kind of evil. They know what they're doing. They know how they're doing it. They know that the medicine doesn't work for anything other than symptom control. They know they're going to have side effects. They know it's very expensive, and yet they still produce it." This is one of those places where profits have kind of violated our ethics and moral responsibility to society,
Yeah,
um, because of the
I
profit
agree.
greed.
I agree.
Yeah.
Um, so we know that Japan, they have a different type of regulatory pathway for biologics and all that, right? And I believe they kind of introduced it like around 2014. So we're talking about, what, 12 years ago? And then the first time I believe that the US put something in place was around 2024. So, technically, in a way, we're like about a decade behind, from Japan.
Yes. Yeah.
Um, can you kind of go over a little bit how they regulate biologics a little bit and kind of what, because here, these biologics are considered a drug, right?
Right. Right.
So how do they categorize that over there?
Yeah. So they differentiate between pharmaceuticals and cellular living therapies, right? I mean, we're putting living cells into human being, and sometimes often your own living cells. And
Hmm.
so they have different regulatory pathways because they realize that a pharmaceutical is a very different product, and cellular products are extremely different. We're putting living cells back into people. So
Hmm.
it doesn't make sense to use the old pharma model or a medicine model to kind of make approvals of a drug. I mean, this whole taking out your cells and doing minimal manipulation. What does that mean? Minimal manipulation. Still, I go back to that. It's ridiculous. If I take your cells out of your body, whether it's from your bone marrow, whether from your fat, I should be able to do whatever I want, and then put them back in. They're still your cells at the end of the day, right? And if I can do that at the bedside, I can do something and put it back in. I'm not changing them to Frankenstein cells. I'm just doing something to make them more powerful or work better and improve outcomes. So this is where Japan and even here in Indonesia, they have different regulatory pathways, and they realize that cellular therapy is very different from drugs. So putting that in the same pathway is really trying to take us, square peg and put it in a round hole. It doesn't make any sense. They're not this. It's comparing apples and oranges. It doesn't make any sense. So this is why the Japanese, the South Koreans, a lot of the Far Eastern countries, China, they have different pathways. The FDA has their RMAT now, and as you said, the RMAT is coming through, and they also had different. And the FDA, to their credit, they did have something for orphan drugs and orphan syndromes, right? Where they had special, I forgot the name, compassionate use. They would allow certain things to be done under compassionate use guidelines, and that's great. I think that's where we should expand those compassionate use guidelines. We know that there's a condition that you really can't treat very well, and we know we can treat it a different way better. Well, why not use it? So let me give you an example. So cardiac disease is the number one killer, right? We know this, number one killer of humans, cardiac disease. Now, most of the time, when you get ischemic heart damage, there's not much you can do, right? Once the ventricle has gotten damaged, it scars down. The ejection fraction, the amount of cardiac output, the amount of blood that comes out, decreases. The muscle doesn't pump correctly. You see wall motion abnormalities we see on echo and MRI. So that heart is not working anymore very well, and slowly over time they'll have more damage, and then eventually the patient has to either go for a cardiac transplant, right, or they have to have one of these LVADs, which is a device which helps automatically pump within the aorta. It pumps the blood because the heart can't. You know what? That's a very, very, very invasive way to treat somebody with heart failure or cardiac disease. We know that we can inject, and this is one of the other reasons I left the U.S. is because I can do these kind of things in other countries that they allow it. They have, under some kind of research protocol or some kind of guidelines or some kind of monitoring.
Some guardrails, something.
Yes, always. No, they're very careful, and other countries, we think, oh well, in some countries they don't have any guidelines. This is not true. They all have guidelines. They all have safety things. They all do it. Some they kind of are more enforcing their guidelines, and others are not. But the point is, every country has those kind of guidelines, and so I can inject stem cells into the coronary arteries, and guess what? After I inject into the coronary arteries, and with that I had peptides, and I had nutrition, and I had sleep, and I had cardiac rehab, and then I had infrared. So infrared laser, usually class 4 lasers, are these very powerful lasers that can actually penetrate through bone. They can penetrate the skull, they can penetrate the chest wall, they can go down 6-7 centimeters into the body. And laser medicine like this is these are not cutting lasers, these are not surgical lasers. This is just laser therapy that kind of goes in, and what it does is it usually works on 2 levels: the inflammation that's going on and the mitochondria. And what lasers do is they make mitochondria stacked. People are like, what are stacks? I'm like, stacks. If you look at the electron microscope of what the mitochondria look like after you've done the laser therapy, is they're all stacked on top of each other, like coins. And all these mitochondria now they're working in series. So before, the mitochondria individually were making maybe, let's just use a ridiculous figure, but 20 ATP molecules. When they start stacking, now they make 2,000 ATP molecules. So now that cell is supercharged. So whatever it is, repair cell, this cell, that cell can now do things that other that would normally not be that possible. Now the cell is supercharged and it can repair at a much faster and much higher rate.
Wow.
Yeah, and so I'll give you an example. We had a patient. I remember one of the German friends of mine called me, and a patient who had really bad. His father had a really bad LAD. So you have 3 vessels in the brain, in the heart. You have your right coronary artery and your left coronary artery. And the left coronary then divides your LAD and your circumflex. That guy got a blockage in his LAD, and the LAD knocked off a lot of his ventricles. So he went down from a normal ejection fraction between most people like 55 to 64%. That's your ejection fraction, means how much your cardiac output comes out. So his went down from a 55 to 10. Now, 10% cardiac output or ejection fraction means that patient is a cardiac cripple. They can't walk across the room without getting short of breath. Their ankles are also big and swollen, right? Because they can't clear the fluid from the lower extremities that well. Anyways, so the father was a cardiac cripple, and then he called me up. He said, "Dr. Shaw, can you do anything about this?" I said, "Yeah, I think we can." So I said, bring him down. We took him to a certain place, and then what we did, we injected. So we did the whole sleep, nutrition, exercise, pre-peptide use, post-peptide treatment, and then we injected the stem cells, and also we did the laser, and we put the laser over the heart. And we did this session. It probably took about a month to do this. We did 1 treatment a week, basically. And the reason we did a week is a week we would let the body repair itself. Yeah, and there would be some time and kind of recover and repair. And so this repair, so what happened was this guy after, and the father was very good. He went to the cardiac rehab. He did all exercises. He was using, the hand treadmill and everything. He was doing all kinds of things. And so he went back to an ejection fraction of almost 50%. So he went from
Wow.
10% to 50% and normal.
What was that time frame?
Yeah, about 3 months. And so then he went back to Germany and he had an echo, because the echo is usually the cardiac echo is how we usually test and look at the heart, most common way that we do, that's easy and cheap and fast. So the cardiologist who was scanning the heart started looking at the patient, looking at the heart, and he goes, "This is not the same patient." And I go, because I was there at the moment. I go, "Yeah, it is." And he goes, "No, it's not." He's like in German, like, "No, no, no, you can't, no, 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 no." And I'm like, "No, bro, check out look at the valves." And he started, because when you can tell, he started scanning the valves, and he goes, "What is this? How did you do?" I'm like, "That part I'm not telling you yet, but needless to say, we can do it." And he's
Yeah.
like, "This is revolutionary. You
Yeah.
can take a patient with 10% ejection and bring him back to normal. That's not possible, because there's scar tissue in this and that." Well, guess what? The body can repair. The body is always trying to repair itself, and it's very actively repairing itself. And if you assist that repair process, guess what? You can regenerate all kinds of parts of the body.
No, I agree. I agree 100%. That's amazing stuff that you're doing. And then that's all in overseas in Dubai.
Yeah, no, it's a different country. Sometimes in Mexico, sometimes Dubai, sometimes other countries that we have to do. Some things we do in China, um, Thailand. There's different countries that, depending on where the patient is, and depending on where the lab is, depending on what materials we need, we'll choose the right place to do it.
Okay.
But
Cool.
yeah, yeah,
Yeah. So at the beginning of kind of the conversation, we're talking about why you gave a couple points why you think that the US is behind a little bit.
yes,
And you mentioned that there are some gatekeepers.
correct.
And I would like to kind of explore that a little bit because, I think that when you gatekeep an industry, I mean, these are like pioneers in the industry that they kind of established themselves as the pioneers.
Yes,
And why do you think that they are gatekeeping, and why not adapt, right, into something that is going to revolutionize, right? And honestly, like the field, but at the end of the day, we're talking about helping patients at the end of the day.
yes. So I'll refer back to, I have a mentor named Edward Klinger, and Edward Klinger is on the tech side and a business strategist, and does a lot of career coaching and career guidance for CEOs and executives that are working at the corporate board level. And he came from the aircraft industry and engineering side. He used to work with what was his name, Ross Perot. So he worked with Ross Perot, and he did some work with him. And he, on the engineering side, he would say, there are certain times that what happens is you have an industry, you have a certain technique, you have a certain kind of model that works, and then something new comes in,
Mm-hmm.
and that's the disruptor. And the disruptor, people always fight the disruptor. They don't want disruption, but disruption is what builds innovation and builds science and builds new techniques and improvements. And if you don't have that disruption, then you're not going to have any innovation. And this is where the gatekeepers are just, they don't want anybody to innovate. They have their product, theirs works well. I'm not saying it doesn't work; it works well, but you can improve on that. And they don't want any improvements because they're going to lose market share. This is not a reason. I mean, science should not be restricted like that, and innovation should not be restricted like that. We should be able to do new and innovative procedures that we know are going to help patients in ways that before was not possible. For example, I know. Okay, I'm here at this Jakarta course. I gave a lecture and a whole workshop on PRP. I've been making PRP since 2008 when I just had my own centrifuge, and I would do it, at the bedside. Yeah, but I mean, and PRP is great,
It's
but
amazing.
yeah, it works great. It has, but are there better products than PRP? Yes. Muse cells and exosomes and these kind of things, yeah, they work better than PRP. Now, there's still circumstances where PRP will work,
Of
but
course.
there's other circumstances where you need muse cells, or you need exosomes, or you need Wharton's jelly, or you need amniotic membranes, or you need some, you want to build a scaffold, you're going to use something like amniotic membrane, or you're going to use Wharton's jelly. Wharton's jelly is a great product. It has lots of more regenerative growth factors than platelets, right?
Hmm.
Yeah, hands down, there's like there's like at least 20 different regenerative proteins in the Wharton's jelly, as opposed to platelets where there's like three or four or five, maybe six. If you're going to do something, then you want to do the best, and you want to use the best product for that specific pathological mechanism, and go after that pathology with the best product you have. And this is why the gatekeepers, I don't appreciate the gatekeepers, but I'm happy to discuss with them and argue with
Yeah,
them, and debate. And
debate.
good scientific open debate is good. And there's some that don't like the debate, and they cancel people, or they close down things, or they close down arguments, or they close down. I think that's just, honestly, that's just weak. You're just weak if you're doing that.
I agree. Yeah. I mean, we experienced that a couple weeks ago, right? To where I like having conversations, right? And, I like asking questions. And we were kind of, the comments were turned off and then we couldn't debate it. And I was like, hey, I was having so much fun, trying to, ask these questions.
Okay, today I talked to a very, very advanced stem cell doctor in the New York area named Ajit Dhaliwal, who's Canadian trained but now works in New York, and he's doing
I
PhD.
know that Ajin. Yeah.
Yeah,
Beautiful,
yeah,
awesome
very smart.
person.
Yeah, very smart guy, very advanced. He's done lots of entrepreneurial things, and now he's doing regenerative work, and he's setting up regenerative clinics in different cities in the U.S. And we were talking all kinds of things. The fact that we were exchanging those ideas, that's how you learn. I learned something from him, he learned something from me, and you have that debate. But when people don't start closing down debates or closing down LinkedIn comments, or start doing, it's like, that's, you're a wuss. I would say another word, but I'm not going to use that word on the air. But that's what you are, and you know it. And if that's if that's the basis of your argument, is to shut down things and not let anybody discuss and not let anybody bring a counterpoint, then you're just weak. And if you're weak, get the hell out of the way. Then get out of the way. Let other people who are a little bit stronger, let them move the field, and let them innovate, and let them do things that are more advanced. If
I
you want to
agree.
go do your little thing, yeah, it's okay, fine. It's like the open surgeons who used to do appendectomies with big scars, right? Yeah, and they got very mad when there was laparoscopic, appendectomies and laparoscopic cholecystectomies. This stupid
Yeah,
laparoscope. We don't want the laparoscope. We don't want this. Guess what? Now all the surgeons use laparoscopy for all their surgeries, right? They don't they don't do these big open surgeries. I mean, rarely now, right? But there was a lot of resistant surgeons, and they resisted, and they kind of fell at the wayside at that point. They're going to fall behind. These guys who are gatekeeping, they are not the most advanced people, and guess what? Their patients are they're doing a disservice to their patients if they don't innovate. Any doctor who doesn't keep up with literature, doesn't innovate, doesn't try new things, doesn't learn new things, doesn't travel and try to find out, get information from somebody who's an expert, then you're doing a disservice to your patients,
I agree
and
with you.
your patients are not getting the best care, and people should know that.
I agree
We're
with you
not,
100%.
that company does not provide the best care for patients.
I
They're
agree.
actually,
And,
they're
I think that now also I've been in what I see, right, is that a lot of patients are also being very, they're educating themselves. They're doing their own research on, they're going overseas, right? And, they
yeah,
honestly, they'll probably go to the clinic across the street if you're not offering something.
right.
You
If
know,
you're
if
so
if
behind,
they
you're not.
really want it, they're going to find it.
Yes, and you're not innovating, and you're behind. Well, guess what? With AI, you can figure out what's the best therapy. With
Pretty
AI,
much.
you can ask the questions, you can get answers, and you know what? Say, oh, well, that doctor, all he does is PRP. Well, you know what? I'm not
Yeah.
going to go to that doctor then.
Yeah.
That doctor just does PRP. I want to do a doctor who knows how to use other. He knows how to use Wharton's jelly. He knows how to use SVF. He knows how to use BMAC. He knows how to
Exosomes.
use
Yeah.
stem cells. He knows how to use exosomes. He knows how to use laser. He knows how to use photobiomodulation. He knows how to use ultrasound, high frequency ultrasound. He knows how to do. He's that doctor is advanced. He's learning, right?
I
And he
agree.
keeps up. He keeps up with whatever the guys who are not keeping up. You know what? They're going to fall behind, and that's fine.
Yeah.
Let them fall behind.
I agree.
Other people are going to lead.
I agree. Yeah. So we spoke about how a few reasons why the US is behind. We talked about regulatory, right? Obviously the FDA and certain red tape that there's there. Obviously we spoke a little bit about big pharma, medical device, right? How most of the doctors are trained within a system that incentivizes big pharma and med device, so they try to stay within there. We talked a little bit about gatekeeping, how certain pioneers and are gatekeeping the industry by not allowing and not having good discourse, good debates that allows innovation and challenging each other, right, to improve. And then also we mentioned about how some, even the ones that are offering, are kind of quiet in the background, not really. talking because now the regulatory of the FDA, they're scared for certain things, right? So now on the bright side, right, there's Utah, there's Florida now, right, that are passing certain laws, right, on the state level, right? So they're saying, all right, all right, the federal, they're not moving things along. Let's take it to the states now, right? So what are you seeing that Utah and Florida are doing a little bit differently?
Yeah. So number one, today's July 4th, right? It's Independence Day in the U.S.
July 3rd. Well, yeah, you're July 4th now.
I'm in July 4th, where
Yeah,
I am.
I'm July 3rd still. It's
But
7:50 p.m. right here.
remember the founding fathers. One of the things that they stressed was states' rights over federal rights. This was very important. This is a big argument that you can see. There's lots of court cases and Supreme Court cases where states' rights were emphasized, not the federal government. You don't want, and they didn't want a strong federal government. They wanted a kind of weaker federal government. When they made the first Articles of Confederation, there was a much weaker central government. And the point was that states' rights should predominate over federal rights. If a state, if a group of people who live in a certain area decide they want to do something, then they should be allowed to do it. And somebody sitting in Washington should not be telling them what to do. And Florida did it. Florida did it first. I mean, credit to Joseph Ladapo and credit to the governor. They pushed it, and they got $5 billion in direct investment within a year.
Wow.
And that $5 billion is going to turn into $25 billion of indirect investment, where people are going to be coming in from medical tourism and coming in for other things, and a lot of device companies are going to be coming in. Labs are going to be built. So you know what? Florida made the smart move, and now Utah, Tennessee, Arizona, Nevada are all jumping on the bandwagon, and they realize. And I've spoken to some of the guys who have helped draft the laws, and they're very forward-thinking people, and they realize that if we have the technology, we have ways to cure diseases. We have ways to fix problems, and not just a pill that you take every day. And if you stop taking it, you get worse. That's not a cure to anything. That's just symptom
Nope.
control, and that's not
It is.
proper medicine. Even longevity market. I always laugh in longevity. Like sometimes longevity guys. I'm here. We're teaching. We have a course. We're doing a course in longevity and regenerative medicine in upstate New York for a week long, and we're going to teach people real longevity medicine. And by longevity, it doesn't mean you're just taking metformin. You're not just taking a pill, or you're taking rapamycin. That's not longevity. Longevity is regenerating the body, so that the body now, there's trials, and now they're doing things where they use Yamanaka factors, and Yamanaka factors, the one that use iPSCs, where they can take a cell like a fiber, like a skin cell, and convert it into a cartilage producing cell. Or they can take a skin cell and they can convert it into a cardiac cell or a brain cell, right? That kind of thing. The same thing with the Yamanaka factors. Now, we can take those Yamanaka factors and we can actually make a cell younger again. We can convert it to an earlier age. So now your cells, first of all, your body will get rid of all the zombie senescent cells. We talk about this as senescence, that there's a bunch of zombie cells. There's a bunch of cells in the body that just, they're not working very well, and they just cause more problems and more inflammation. Now, we know one of the best ways to do that is fasting, intermittent fasting, right? Where you increase autophagy. Autophagy means self-eating, where the body kills those little zombie senescent cells, gets rid of them so that new cells can come in. The new cells are younger cells, and they start producing like a younger cell again. And now, where the skin cells, you've regenerated the skin, or you've regenerated the bone. The bone, bone is one of the fastest turnover tissue in the body, right? The liver and the bone, they just, as soon as they have some damage or something, they turn over quickly. You have osteoblasts and osteoclasts in the bone. In the liver, you have your hepatocytes, and it's amazing how much regenerative capacity the body has. We always talk about the salamander, and you cut off a leg off the salamander and it grows a new leg. Well, guess what, boys and girls? You can do the same thing with the liver. Our liver, you take off a large part of the liver, you can take out 70% of the liver, and it grows back. I look at the stuff that I do with interventional radiology, where we go in catheters and wires into the body. We actually embolize, we block off a part of the liver vessels, and it shrinks down. And guess what?
Wow.
The other part of the liver gets bigger. It hypertrophies. So, the stuff that we can do, it's incredible, and how the regenerative capacity of the body is incredible, right? So you can regenerate all these tissues. You can regenerate cartilage and bone and brain. Let me give you another example. We do for Parkinson's, right? Obviously not in the U.S., but in other countries, I will take a catheter into the brain. I will take it to the area where dopamine is produced, because Parkinson's is a lack of dopamine, where the substantia nigra part of the brain, that nucleus doesn't produce enough dopamine. The dopaminergic neurons have kind of shut off, or they're slowing down, and they're going into senescence. what we'll do is we'll inject stem cells and exosomes and secretome product, kind of our little mixture. We'll inject it into that substantia nigra. I get dopamine production within a week. I can measure it. Then I get normal dopamine production within a month. And at 3 months, we're getting more dopamine than they ever had before. And the patient's symptoms are improving. So you can take a Parkinson's at stage 4, you can convert them down to a stage 1 or stage 0 by delivering the stem cell product to the right area. It can be done. Why is it not being done in the U.S.? Because that's the sad part. And you know what? The U.S. has some of the best scientists, some of the best researchers, some of the best universities that fund research. But the problem is that converting that research to what we call translational work is still very slow, and that's because of just what do you want to say? It's guidelines, or it's a obstruction.
Yeah, well,
or there's powers that be, like the device and pharmaceutical companies, that just don't want that coming because they know they're going to lose profits, which is
wow.
sad.
Yeah, I mean, wow, the stuff that you're working is insane. I'm sure people that would hear that, I was like, what?
Yes.
Yeah,
No,
and
for example, Alzheimer's. No, so in
no,
Alzheimer's, most of the time it's at the hippocampus level. You see atrophy, you see decreased function. If we do a functional MRI or we do a PET study, we can see that the hippocampus function is decreasing, less blood flow, and it's not working as well. Well, guess what? We will inject the vessels that supply the hippocampus with blood, and we'll put in stem cells or regenerative products and exosomes and a secretome, and we can get that hippocampus to anatomically look bigger, right? So it's not atrophying anymore; it grows back. And with functional studies, with functional MRI and PET, we can see that it's functional again, and it's working again. And guess what? The patient's memory problems and brain fog and all these other issues, and where they're forgetting where they are, they're forgetting who their
yeah,
family is, their memories come back. They come back. Yeah, it's amazing. It's incredible actually to see that. And you see somebody who is a very frail Alzheimer's patient who can't walk very well, is losing their gait, doesn't know who they are, doesn't know where they are, continually gets lost, misplaces this, starts getting violent with their family because they feel they're in an environment where they don't know who the people interacting with them are. They've lost their personality, and we can bring those patients back.
that's
But we're
amazing.
still restricted to do that in certain countries.
Let's say if you were the decision maker here in the United States, let's say a president,
Yes.
and what would be the solution for the U.S. to catch up in the science and catch up with the rest? Like, what would you do? Like, if
Yeah, so here's what I'm going to tell you. I'm going to use Dubai as an example. When Dubai wanted to encourage certain industries, they built certain focal areas, economic zones. And in those economic zones, the laws were different. It's basically what Florida, Utah, and all these other states are doing. They're making their economic zone, but you build these little biotech centers. So Indonesia is doing that, right? Indonesia has 3 specialized economic zones for health and wellness. Other countries do the same thing, where they build ecosystem, and the rules, laws, and regulations are different in those economic zones. And of course, there's a lot of regulatory authority. There's still people that are kind of watching and making sure that things are done properly and safely. But in those specialized zones, innovation is allowed, and people can do different things and try different things, and patients can get some benefit. I think this, I mean, the U.S. is doing it already with states. Florida and Tennessee in that area are going to be miles ahead of all their neighbors, and they're going to be there. And I mean, it's funny how things recycle, and using PRP and using blood. It's always funny. People talk about, stem cells and regenerative medicine is very new. No, it's not. And they're like, what? I'm like, I always give the story of Countess Bathory, right? So this was a Hungarian countess, right? So this Hungarian, she was related to the King of Poland and the Prince of Transylvania, right? So she used to get blood from young girls. Some of it she would consume, some of it she would bathe in, and it would make her younger, and her skin would look younger. In the olden days, now we use placenta and umbilical cord cells. The olden days, if you had a skin lesion and a baby was born, they would take the placental blood and rub it on the skin. And guess what? It would clear up the skin lesion. So this regenerative medicine and these kind of things, they've been here there was a very famous pope, I think it was Innocent the third or fifth or seventh, I don't remember which one. Anyways, he was very sick, right? And he was dying. And they took some blood from 3 young children, and some of it he consumed and some of it he rubbed on his body. I don't remember the exact circumstances, but it temporarily kept him alive. But then unfortunately. He died, and the 3 kids they took all that blood from died. But the point is, people were
That's
doing
bad. I'm laughing at the story. Oh my God, I'm sorry. I'll take that back. No.
yeah. Oh, no, but I'm saying that this use of blood rituals
Yeah.
common in many different cultures. You see in the Incas, and the Aztecs, and the Mayans, and the Sumerians, and the Egyptians, and the blood is life giving, and we know that blood is life giving, and using blood to do that is something that's as a concept has been there for thousands of years. We're just rediscovering it again, or using
Yeah.
light therapy, right? And like light therapy, the Romans and Greeks had solariums. The 1905 Nobel Prize, I think it was Christensen, got a Nobel Prize for treating extrapulmonary TB. So the TB that's not in the lung, treating extrapulmonary TB with light therapy, and he got a Nobel Prize for it.
What?
Yes. And the laser, the photobiomodulation lasers and stuff. The Russian. You know who developed all this? All this stuff that we're doing now. The Russians developed a lot of this. The Soviets specifically, right? But the Russians after the wall fell. But for example, they peptides. Dr. Khamensin in Moscow, right? Khamensin was the leader. I remember meeting him in Moscow and talking to him and spending some time with him. Khamensin was the godfather of peptides.
Hmm.
Photobiomodulation. They were doing laser therapy way before everybody else with UV and infrared light. They were doing heat shock and cold shock proteins, where you do sauna therapy for the heat or steam therapy for the heat, and then cold immersion for the cold. And you get heat shock proteins and cold shock proteins, and then the patient's body is resistant to these different elements and stuff. So using the lasers and stuff, they would actually. So these Spetsnaz, right? So the Russians have their special for, like in the U.S. you have your SEALs, and you have your Rangers, and you have your Green Berets, and you have some of the Navy, other Navy ones, and you have whatever. You have all these different special forces. The
Yeah.
Russians they have Spetsnaz. Their Spetsnaz are these really amazing, super warriors. When they started doing all this training, right? Because this is the Cold War time, they used to be able to increase their total lung capacity. Right, they would increase their total lung capacity 30%. They would increase their functional residual capacity in the lung 30%. So these guys' chest walls would actually have to get bigger because the lungs are getting bigger, right? And then their cardiac output, they could increase 30%. Their skeletal red muscle mass, they could increase 20, 30%. Fast twitch fibers in the muscle, they could increase fast. Neurocognitively, huge improvement. They could think faster, plan faster, strategize faster, shoot faster. Right? So these are like, even they're like Captain America Russians, right?
Yeah.
They turn these people into super soldiers. And
Wow.
these super soldiers could do all kinds of things. And the same thing they did for their cosmonauts, their astronauts. They used to put them through these kind of trainings and different therapies and stuff also. And I can tell you, when they have competitions between the Spetsnaz and special forces from many other countries, the European countries, North America, guess what? The Spetsnaz win every single time. And then other countries will be like, well, they're just doping, or they're just doing this, or they're just steroid roads. And no, they're not. They're using natural therapy. They're using light therapy. They're using peptides. They're using all these things to improve their health and become stronger. And I think this is. I wrote an article on LinkedIn about longevity. Longevity is great, but if you don't have brain span, and you don't have cardiac span, you don't have all those things. If you're not increasing you're not making things improved. Just keeping people alive longer is really not worth it. But if you can have somebody who's 70 or 80 and make them function at the level of a 40-year-old again, that's impressive, right? And that's what longevity should be. You should be able to regenerate the body and bring them back in time.
Yeah.
And there are people in other countries that are doing it. That's why, as I said, the U.S. is behind, unfortunately. But I think the scientists are not. I think it's just the
Yeah.
medical community. The medical community is kind of behind. And then what are you going to do? You're going to have to go get. Patients are going to have to go to Mexico. They're going to have to go to other countries to get some things done. Might have to go to China to get things done. I mean, I had a friend of mine who got pancreatic cancer. I said, listen, you need to go to China because they're more advanced in what they do with pancreatic cancer. They can actually cure it, as opposed to the U.S., where he was in Canada. They'll do chemotherapy, radiation therapy, and you'll still die. It's not worth it.
Interesting.
And that guy was alive 2 years longer than he would have been if he had not gotten treatment.
Hmm.
He would have
So
done 6.
for what I have a question. What advice would you give to a physician that is curious about, stem cells, regenerative medicine, but they're
Yes.
afraid of, malpractice? Like, what advice do you have for them?
So I would say, listen, just like anything else that we do in medicine, go get trained. Go seek out, go learn, do some CMEs, go to some courses, go to the ABRM, go to the A4M, go to the big conferences that do regenerative medicine, talk to the people who work there, learn the techniques, go learn from somewhere. Like we have the reason that we have our course is specifically we want more people trained in it. We have a cadaver course, so we have cadavers, so you can learn how to do the procedures on a cadaver. You can get very comfortable with ultrasound. You can become very comfortable with fluoroscopy. So you can inject stem cells into a knee or into a shoulder or into a soft tissue structure or somewhere else. So you will be very well trained, and we'll teach you the protocols. We'll teach you protocols, and then later on we'll still give you also a mentorship. So if you want a proctor to come in, let's say you have 10 cases scheduled, the proctor will come in and help you do the 10 cases. And guess what? You will become very proficient very fast. I mean, that's how we teach. That's regular how we teach medicine, anyways. When something new comes to the medical field, that's what people do. Like, for example, robotic surgery. Well, robotic surgery is something fairly new. So doctors go and get trained. They go to courses. They go to where a robotic surgery center, and they get training on the robotic machine, and they can do robotic surgery. The same way with stem cells. You have to go out, seek the information, find the people who know what they're talking about, and try to get as much information from them as possible.
That's a great advice. Yeah, and there's tons of resources out there, right? I mean, if you really want to know, I mean, you can here in the United States, outside of the
Yep.
United States, I mean, there's a lot, right?
Yes.
You
Yes.
just have to really seek it.
Yeah.
So, where do you see regenerative medicine in the next 5 years here in the United States specifically?
Yeah. Well, I mean, I think you'll see the stuff that we're doing in China and Japan coming here eventually, and people doing things which are more advanced. We can start. I think the next step is going to be regenerating actual organs, right? We're going to start regenerating kidneys and lungs and heart and regenerating brain and different parts of the body. I think that's the future. Now, if we continue having obstructions to innovation, then the U.S. is going to fall even farther behind. Other countries will start doing it much faster, and they will regenerate organs. And once you can regenerate organs, then we can just replace them, right? If we people already in Israel and a couple other places, they already made like mini kidneys or mini hearts.
Wow.
You have to make it to the maximum high normal level, normal size. You can actually regenerate the whole organ, and you can improve people's health span and lifespan much more significantly than just taking pills and not doing anything really.
Yeah. So, obviously you're here in the United States. You're going everywhere. So what are you mostly focusing on right now? Like where, what are your what's your goal?
Yeah, so my goal right now is two things. One, bring education to the U.S. and teach people things that they've never heard of, or they've never tried, or it doesn't exist in the U.S. right now. That's one. And the second thing is to establish some centers of excellence where we are doing the most advanced stuff, and then we can teach people. If people want to learn, they can come to our center in Nevada. They can come to our center in Michigan. They can come to our center, hopefully in Dallas. Hopefully, in Dallas, and we can start doing things and start advancing, and doing innovative things, and being a little bit of a medical disruptor. That's okay. Being disruptive is good. Disruption, breeds innovation. And so we're going to have to kind of do that. And we'll have to little bit fight the powers that be and people who, block people, other people, and don't allow conversations to happen and start deleting comments. Okay, fine. Yeah, we'll deal with you guys elsewhere. We're not impressed. I'm not impressed.
Yeah. Yeah. Okay. And and what are you going to be? So what are some examples of those of some therapies that you're going to be bringing, right? And then how some good examples, right? So the audience can kind of hear and like obviously like look into what you're going to be teaching, right? And then how do they know that they are able to practice? Like, how are they going to be able? So because if it's not, let's say allowed in the United States, right? Then how are you going to break through as well, right? Because obviously knowing how to do it in a clinical setting, obviously you have clinical trials, you have
Right.
IRBs, you have certain things. There have some legal pathways like the expanded access program. You have the right to try depending on all of that. How do you expect to navigate that?
I think that we're going to have to partner with industry. I think our industrial colleagues, the ones that are building the cells, building exosomes, producing those things, they have to sponsor the education. they have to bring it forward. I can tell you medical devices, because I'm a neurointerventional surgeon and interventional radiologist. Medical devices used to take us for training all the time. When we were fellows, they would take all the fellows and go take them to a training course. Or even when we were staff, they would take us to a training course. They would take us here, they would take us there, and let us teach and let us learn. And that's going to be, I think, industry is going to have to help. And then, of course, the public health authorities are going to have to kind of jump in and say, you know what, diabetes is a huge problem, or liver disease is a huge problem, or heart disease is a huge problem. And if we're going to really attack these things, we have to be preventative. And preventative is going to be regenerating parts of the body, then, right? So that's the best kind of preventative medicine, is regenerating parts, so you don't get a heart attack, or you don't get are going to have to be done, where there's going to have to be what we call public private partnerships, and then again government and industry partnerships, where they'll have to be private industry working with government and working with doctors. And then doctors have to kind of break out of their comfort zone. If you really want to, you have to get out of your comfort zone. You have to kind of, okay, I'm not just going to write a prescription every day, write a blood pressure pill, write this, and then that's what I'm going to do all day. Or I'm going to write something that's just going to be a medicine.
I think a lot of them are waking up.
Definitely.
They're getting tired of the system. They're looking for alternatives. They have their patients asking them, right? Hey, I have peptides. I want peptides, right? And if they're not offering it, then they're gonna go to someone across the
That's the
street.
problem. So eventually, people will find. When people want something, they will find it.
Yeah,
And
of
gatekeepers
course.
can gatekeep as much as they want. At a certain point, people will find what they
They're
need, and they
gonna
will.
go around. Yeah,
Yeah, they're going to go around. They're going to find. This
yeah,
is why people go to Mexico. People go to Japan. People go to China for treatment.
yeah. You mentioned something just now, that you believe manufacturers should be paying, like for example, manufacturers that are manufacturing, these stem cells, right? You're saying that you think you think that they should pay for the education.
I think
Uh,
so, and this is what medical device companies do.
yeah, I agree. Now, I agree with that, right? Someone needs to fund it, right? Do you think that that will be a little bit biased though? Because then, a company will educate, that's, what are your thoughts on that?
Yeah, that's a very good point. Yes, then you're going to be only focused on one product, but no, you should know if you have training, you should have two stem cell companies or two exosome companies
Okay.
sponsoring, so that
Yeah.
people can go, okay, I'm going to go see that, and I'm going to see this company, and I'm going to see this company. I'm going to talk to both of them. I'm not going to focus on just one. So
Yeah.
it should be open. The funding should not be just sponsored by one specific company, but let other companies also come in, and then let the marketplace decide, right? Let the free market decide what's the better product, and what's safer, and what has better outcomes, and then the market will decide, okay, this is a better one. This is what's going to succeed. The other one is not very good anymore.
Yeah. The market always dictates, we can try, but the
Yes,
market dictates where it goes.
that's right.
And you
And
can
that
gatekeep it, you can do whatever you want, but people are going to find a way.
and that's the way it should be, right? The market should decide what is good and what's innovative, and and then somebody will fund it, right? They'll say, oh, this person has this new innovative idea, and they want to do this, and they want to do this. Oh, well, then somebody should fund it then. And I think education, even I think the government should start funding this now. At a certain point, the government should jump in and be training residents in medical programs and medical schools in stem cell medicine. And unfortunately, I will tell you, there's very little training in medicine and residency on stem cells,
Yeah.
which is really a disservice to doctors and their training.
To mankind.
Yes, that's right. That's right. No, exactly. It's that you're stopping humanity from being the best that they can be. Just for what? For profits? For pure profits from somebody else? Makes no sense.
Essentially, yeah. Yeah. So, I'm a very optimistic person. I guess, that saying, I look at the glass half full, right?
Yes. Yes.
And I always look at the positive side, and I always, as an entrepreneur, I always try to find solutions, right?
Yes.
And what do you see in the stem cell world and regenerative medicine in like the next 5 years?
Yeah. No, I think you'll see in the U.S. more and more states jumping in, um, and the FDA kind of taking a step back and say, okay, let's see what people can do, and if there's some unsafe people, or there's some crazy, and I know there's some clinics now in Florida that are saying we can cure autism, or we can do this, or
Oh,
we can do that, or whatever. These fly by night clinics. Okay, you know what? Fine, like let somebody kind of shut them down. But at the end of the day, you know what? The free market will decide, and people will choose what they want. And now with AI, they have access to a lot more information than they did before. And that access to information is going to lead them to go to other practitioners and not the local doc in the area who just has not kept up with things. They're going to go to a doctor that is way more advanced.
100%, I agree. So, okay. Do you have anything else that you would like to share with us? Like, for example, I know that you have the training coming up in New York and Utica next month, I believe.
Correct.
Can you talk to us a little bit about that? And
Yeah.
then,
Yeah, so that'll be cadaver training. There'll be peptide training. There'll be longevity training because we have both the American Board of Regenerative Medicine and the American Board of Longevity Medicine sponsoring that training. And I can tell you, having been to other stem cell courses, this is definitely the most advanced course in the U.S. Very few stem cell, actually, I've never seen a stem cell course that having cadavers. They don't usually have cadaver training. Usually surgical courses and other type of pain management courses have cadaver training. But regenerative medicine has not. So one, we have cadavers. Two, we have some of the top peptide experts in the world. We have somebody named Jean-Francois Tremblay, who is going to be joining us, and another person, Miss Shirley, who works with me in Dubai. And these are super experts. I mean, Jean-Francois knows everything about peptides. I mean, he's been doing this. He's doing peptides for more than 20 years. I mean, he was doing peptides when nobody ever heard of peptides. And he was manufacturing peptides when nobody ever heard of peptides. And guess what happened to him? So he had his factory in Canada. Well, Canada had Health Canada. And Health Canada was run by pharmaceutical companies, really, right? The pharmaceutical companies decided, and they shut him down. He had a manufacturing facility, factory, everything, and he was doing really safe, clean peptides, right? That was a big thing, that his peptides were not like some of the, unfortunately, some of the Chinese or Indian peptides that were, adulterated or having heavy metals or other things. He had pure, clean peptides, and
wow,
they shut him down.
so
Unfortunately.
unfortunate.
Very
So
unfortunate.
unfortunate.
Very unfortunate. But
Yeah.
anyways, I think he's kind of brought himself back and he's reinvented himself in the U.S. and Spain.
Yeah. Sorry about that. I don't know if you can hear my dog. Someone banged the window. So,
That's
okay,
okay. All
cool.
right.
Yeah. So, okay. So, Dr. Shawwell, I'm looking forward to seeing you over at the conference. I know you said that you were in Jakarta, right? Like, are you gonna do a speech out there?
Yes, I have. I already did one. I did one training session for peptides, and I have another speech today on neurorestoration for CNS. Because what I do is I inject stem cells into the brain and through the arteries, and I still think this is probably the best way because understand that's the way the body delivers stem cells. You have stem cells in your bone marrow. You have stem cells in your fat. Those stem cells are delivered through the arteries. And we say arterial blood is very different from venous blood. So arterial blood is richer in oxygen, it has a higher oxygen tension, it has more hemoglobin, it has none of the waste products, it has all the regenerative proteins and factors. It's a more rich medium for growth. And when your body delivers stem cells, guess what? They deliver it through the arteries, not through the veins. The
Yeah.
veins blood back. I call that sewer blood sometimes. Now, for a pharmaceutical product that can go through the lungs and it'll work. But for a stem cell product, if you're injecting, a lot of things will get caught up in the lungs because the lung is a great filter.
Yeah.
So when you inject it intravenously, you don't get the effect that you will get with arterial injections. But not everybody can do arterial injections, unfortunately.
Okay. So where can people find you if they
Yes.
want to learn more about you?
Yeah, so we have the website up. It's called OMNI RMETI, OMNI RMETI.com. And then we have the other website was Omni Regen. I think that Regen one is coming up still. But we're talking about doing training for people so that we want people to be, if you come to this kind of course, you will learn not only how to do the procedure and not only the protocols, but you'll learn the business side, right?
Yeah.
And you'll
It's
learn
huge.
the compliance side, and the business side. So you're safe, you're doing things safe, and you're making money from it, and you're helping patients. At the end of the day, that's what's really important is helping patients.
Awesome. Okay. Yeah, and then I know you're big on LinkedIn as well.
Yes, I try to.
I see you commenting everywhere.
Yes, I do. I try to encourage debate and innovation, and sometimes a little disruptive. But I think this is the kind of thing that we need. We need
I,
a little shake up once in a while.
we need to poke some bears.
That's
Get them activated and get them talking, right?
that's that's exactly right. That's right. So
Okay.
it's good.
Yeah. Well, Dr. Shaw, it was a pleasure. It's always a pleasure talking to you, picking your brain, and getting
No, and
everything that's in.
we got a good free exchange of ideas, and we kind of think about things, and you talk about something. That kind of constructive dialogue is always good.
Correct.
You always learn a lot more, and you walk away from the conversation. I always say the best form of knowledge transfer is not books or computers or AI; it's human interaction. and social interaction. And this is when I talk about longevity. Also, I talk about, one of the things that people in longevity forget completely, they never talk about it, is spirituality and social connection, right? So all those blue zones where people live to 100 years and 120 years and things like that, guess what? They have really strong spiritual connections and really strong social connections. And that's one of the parts of longevity which I think is still missing. And people are very science focused, but they
I
have to
agree.
think that, when people are in a community, people have good social relations and healthy social relations, it makes you live longer.
Yeah, no, definitely. I agree with you 100%. So I'm sure we'll definitely have more. I'll put, all your information, the websites that you mentioned, everything on the description. I'll
Thank you.
share that, your website, your LinkedIn profile, all that. So anyone that's listening to this can literally follow you and follow your work, follow your training and get
Yes.
trained. Um, have a beautiful day in Jakarta.
Thank
Okay.
you.
Good luck on your speeches and your lectures and all that. I'm sure you'll kill it and you'll educate a lot of people out there.
Yes, that's the goal. That's the goal.
All right. You have a beautiful day. Thank you guys for joining us today. I'll see you
Thank you.
guys on the next one.